It's a good question. There definitely should be. And we're certainly aware that the state had worked actively to develop supply chains as well as manufacturing in the local area. So I'm a little bit perplexed at why it is that we have not seen the state. I can understand why we haven't seen the federal government because everything seems to be up in flux in the federal government right now. But certainly the state, if they have the stockpile and the systems have the stockpile, our position is, and this isn't even to the highest standards it should be, but at a minimum, we should be seeing that every nurse who is doing direct patient care should be getting a new N95 mask for every shift. And those who are in direct care of COVID positive patients should have full PPE. I don't understand why we wouldn't do it. And I certainly think that in the beginning, we suspected it was aerosolized spread as well as large droplet. We were proven to be correct in our assumption. And that was a precautionary approach. Like if you can't disprove it, then you assume it's true rather than assume it's not true. So all the more reason why our position is people should be fighting for N95 masks on the beginning of each shift along with the face shield or goggles. There's a new set of guidance out. So the original guidance that the state put out in the first wave, and then they just put out a new set of guidance too, which actually you can click on the Mass COVID site, or we have it up on our website as well. But the way it works in essence is the elective cases, if you will, are kind of tied to how much available bed capacity the hospital has. It's supposed to be that as long as the hospital has 20% bed availability, then they can continue to do they can continue to do elective cases. And at the point that they don't have that bed capacity, which means that they would be tight for a surge of COVID patients, then they would have to reduce or stop the elective cases. We have not heard that there's going to be a push by the state to just shut down elective cases and then move those people to help with the COVID unit. It seems more like, hey, if you have the capacity, you can continue to do elective cases. If you don't have the capacity, then you shut it down, as opposed to, we're going to ask you to do this so that the staff can be redeployed. That does not seem to be the way this is set up at all. Having said that, and it doesn't take a rocket scientist to look around the country and see that, a lot of the states that weren't in the heavy portion of the wave the first time around are feeling it in spades right now. Simple math tells you that if 10 to 20% of the people are going to have a more difficult time with it, then if you keep doing 2,000 plus cases per day rising, that at some point you're going to be at a capacity problem. So I would suggest to the staff now, you have your voice, your collective voice. You should be sitting down now to talk about how it is that COVID patients are going to be taken care of. They should be cohorted already. I think that there's some magical math going on in terms of bed capacity so that they don't have to stop the elective surgeries. And I also think there's some pretty magical math going on as to part of cohorting patients, because some of it I understand that the institutions know that nurses don't necessarily want to be deployed directly to COVID patients after the experience the first time. It's hard work and it's nothing that anybody's looking forward to do right now. But on the other hand, lying to people is not going to be a solution either. So if we need to get into it, we might as well sit down and figure it out. Whether we rotate people in and out on a voluntary basis over a period of time just to help with the burden of it, coming up with proning teams, running teams, we need to have all of that in place now. So in short, it's not directly tied to shutting down elective cases. It's tied to capacity. But, look around you. Sit down now and start negotiating how you're going to do it, because it's going to be at our doorstep within 3 weeks. By the beginning of the year, it seems hard to believe that we won't be at capacity. Most of you know, and I have said repetitively, it seems to me the standards that we're imposing in non-healthcare settings are better and stronger than those that we're imposing in the healthcare sector. And that's, quite frankly, an embarrassment. It should be, and CDC has said, that essentially if you've become in close proximity with a person over a period of time that's positive, then you should be quarantining for 14 days. So what that translates to is, if you have a patient that's positive and you're wearing PPE, That's great, except for the fact that we all know you still have to eat and you're still in the break rooms and whatnot. So there's still a level of exposure there. And as we're seeing some clusters break out inside the hospitals because there's no way 100% of the time to have the mask on if you're eating and drinking and whatnot. So there is some risk there. So erring on the side of safety is a better way to go, as we are with the public. And most certainly, if you have somebody in your household, if you have, let's say your child comes home and it turns out they're positive, you're going to be around your child all day, and you've already been around them for 3 or 4 days leading up to the fact that they were positive, or a spouse, partner, whatever. That's enough to say quarantine, and you should notify your town or city so that they're aware of it and that they can also check out any contact tracing that they need to do. The whole point of this is to stop the spread. So I think the gut instinct of the nurses, and knowing that it sounds a little hinky for me to say that my spouse, my family should all quarantine, but I can go to work, if that doesn't sound right, it's probably because it isn't right. And you should follow what the town and city is saying and quarantine. And all the more reason, as I said earlier, your committees need to be sitting down and talking about how we're going to handle that, we're going to backfill staff, how we're going to handle when people are out, what time they use. If they turn out positive for workers' comp, that this not be contested by the institutions. All of those things are important matters to be taken up, and not the least of which is we should also be taking up the issue of testing. Again, this double standard where we're seeing a lot more testing done in the school system, and in some cases we're not seeing adequate testing done in the healthcare facilities. So testing, I think, equally important to be done. The more we test people, the more we have security knowing how to contain, if you will, the virus while we continue to do the work that we need to do, particularly in the second wave now. This question, I think, is starting to elevate the anxiety of the nurses, and I understand that. And I think it's probably because you have a better understanding about how vaccines are normally produced and the amount of time and testing that it takes before there is approval to release a vaccine into the public. Having said that, these are all on sort of a rapid fire development, and there's already been discussion of giving emergency orders to go ahead and allow the vaccine to be distributed as soon as possible. I can understand why that would make people a little bit nervous that, frankly, we don't appreciate being the guinea pigs on the front line without adequate PPE, and I'm not sure that we want to be the guinea pigs for anything else either. We get it. Our position is that this should be voluntary. I think if you just tell them it's available to them to take it and that you're not questioning people who might have a legitimate reason not to take it, it will be fine, and we'll see more than 90% of the people probably taking it to begin with. So it's been a while since I had an opportunity to talk to everybody. So, and I know we're headed back into the surge here. So there's a couple of things that are happening legislatively that I just wanted to make sure that people are aware of. We put forward presumption legislation. I know that people have been running into problems where they're put in for workman's comp because they've been tested positive, and we want people to do so. It's going to be extremely important that we have data on the number of healthcare workers that have turned up positive, and we can't do that if people don't go ahead and put in for comp. You may or may not really need it, or it could be a short duration, but it's important to have that data on hand. And it's also important because we really don't know what the latent effects of the virus might be. But I also know that employers have been giving some of the nurses a runaround on this. We've made it clear from a legislative standpoint that all things being relatively equal, the likelihood is that if a nurse is positive, it's been because of the workplace setting. That's the most likely place that you've received the virus or got exposed to the virus. And given that, we want legislation passed that if you're positive, it is presumed to have been in the workplace, and there's not going to be any contesting of the unemployment. I think if you go through it, we're finding we're winning, people are winning and getting it, but you shouldn't have to go through yet another labyrinth of issues in order to get recognized for what, it's common sense at this point. There's another number of other pieces of legislation that are also important, but I also wanted to talk about something that really is something we don't want to happen, and we've worked on it, but this is an opportunity for me to get out to everybody and explain why it is that we're taking this position, and this is over the issue of nurse compact. What that is a number of states have entered into an agreement, a consortium, if you will, that would allow licensure to be shared across state lines. So if I became licensed in in the state of Montana, that Massachusetts would then recognize that license here in the state if we join that compact. It sounds very appealing on the front of it. Here's the problem. When you cede the licensure into the compact, you cede the licensure and the control of it into the compact. Having the legislature cede away control of that licensure is extremely dangerous and just a poor choice. We've seen that now happen where we've seen some states, for example, Montana, who had then sought to extricate itself from the compact and now is unable to do so. I would not want to cede away that control. It's lowering the standards from our standpoint. There is no real reason to do so. Everything they've argued as a reason to do this can be accomplished in a multitude of other ways without ceding our control. A perfect case in point, if there was ever a time in a pandemic, one would think, oh, if you have compact, you could have all these nurses in here. Well, number one, if you're a pandemic, everybody needs their own nurses for the most part anyways. And as we saw with our state, you can immediately pass emergency licensure issues, which we did here to resolve that problem. There are many other legislative things that our leadership can be doing that would actually respect the work that you're doing. And compact is most certainly not one of them. It's hard to believe, but the year 2020, as you know, was the year of the nurse and the year of the midwife. And it's been quite the year. I had asked before, and I would remind people to take a moment to write down some of your thoughts as you experience this. I know it's like you get tired, and at the end of the day, the last thing you want to do is write down what you just experienced. But I think it can be cathartic, number one, and I think we're going to need to look back and debrief after this is all over, and your thoughts from the front line are going to help us determine what do we push for going forward so this never happens like this again. And then obviously take some time for yourselves. My God, if there was ever a group of people that deserve it more, it's you. To take some time out to make sure that you get a moment in there to get some laughter in, because it's desperately needed. And I guess last but not least, I know I say this every time, but I can't thank you guys enough. The words just cannot do justice to what you're doing right now. It's very, very much appreciated, and it's an honor to work to try to make sure that we can support the work that you do on the front line. So thank you.